gone 12:30, so thank you everyone who's joined us at the moment. We're just running a really quick poll just to get an idea of what your level of knowledge is at the moment in regards to managing cholesterol, specifically around this time during the pandemic. We understand primary care services, as well as all the other services, are under a huge amount of stress, and patients and healthcare professionals have told us that they are struggling, that there is a lot of challenges going on. So we would love to have an idea of how confident everyone is on the line as to how they would deal with things. A bit of housekeeping before we start. So all our webinars are recorded. So this will be available after the fact. If you missed something, or if you want to come back and check, or if you need to dip out in the middle, you've missed your lunch, you've got a busy clinic, please do go and deal with that, and then we'll record this and put this up later. We can not see or hear you. We have a Q&A section where you can post questions. We've had some questions in by email in the first instance, so we'll have a look at those. But you should be able to see and hear us fine. We can't see or hear you. So don't worry if you do anything in the background, anything's going on, everything will be absolutely fine. So I'm Chris, I'm the head of healthcare at Heart UK. I've been chairing a few of these webinars now. I'm a nurse by background. I've specialised in cardiovascular disease for around 10 years. And I'm here to chair this session with Dr. Dermot Neely. You want to introduce yourself, Dermot?
Hello, Dermot Neely here. Thank you for inviting me to participate today.
Dermot is a lipidologist. So couldn't get a better expert to talk about cholesterol management, which is fantastic. And it looks like most people have done the poll. Fantastic. So for the most part, I can see on here, let me just end that now. You can see, hopefully on your screen, that the vast majority of people are either not sure, not confident, or not confident at all. So this is a lot of what we've heard in line with through our helpline and professional membership, that people are struggling. So hopefully we find that this session is useful for you. Okay, so if we just start off then with the sort of introductory section of the challenges that people are facing in primary care of getting access to both cholesterol testing and treatment. Over to you, Dermot.
Yeah, well, I mean, the biggest question that we've been asked through the helpline and through the website is whether it's safe to continue cholesterol-lowering treatment during the COVID-19 epidemic, and whether being on lipid-lowering therapy might in any way put you at greater risk of side effects, for instance, from the lipid-lowering therapy itself, or a greater risk of a severe outcome with COVID-19 infection. But what we've been saying, and we've been saying this very strongly, as Donald Trump would tell us, that statins particularly are cardioprotective medications at achieving good control of LDL and non-HDL cholesterol, improves the health of the endothelium and the cardiovascular system. And it appears that people who have pre-existing cardiovascular disease do seem to be at particularly high risk for a poor outcome with COVID-19 infection. So for that reason, we believe it's very important for people to maintain their cholesterol-lowering treatment during the COVID-19 pandemic. There are some other risk factors that have been identified for a severe pneumonia with COVID-19, and particularly hypertension and diabetes have been identified, along with obesity and chronic pulmonary conditions, as you might not be too surprised to hear. But the evidence is that being on a statin during an episode of severe illness certainly does not reduce the likelihood of a good outcome. In fact, many studies have seemed to show a slight advantage in being on cholesterol-lowering statin treatment if you happen to get an episode of sepsis or pneumonia or other severe infection. There was a letter appeared in the BMJ quite recently, which has mentioned that people with severe COVID-19 infection appeared to have low cholesterol, and that the interpretation put on that by the author of the letter was that having a low cholesterol was a risk and that you should stop your statins. But we completely, if you like to debunk that. We know that any severe infection reduces cholesterol, including the LDL, non-HDL, and the HDL fractions of cholesterol. And this is part of the acute phase response that's seen in severe infections due to the effect of a wide range of cytokines that appear in the blood during infection. And this simply therefore reflects the severity of the illness, and it's in no way can be interpreted that having a low cholesterol increases your risk. Quite the opposite is likely to be true, that having well-controlled cholesterol will give you a more healthy cardiovascular system. So therefore, I'd say it's certainly, there's no evidence that it is unsafe in any way to continue statin therapy or other lipid-lowering therapy during the COVID-19 pandemic. It's certainly safe to continue. One of the issues has arisen is people aren't been able to access the normal monitoring of their medication. And I would say as long as people are on a stable dose and continue to take that, they should just carry on. We know that it's nice to get regular blood tests to ensure that you're in good control for the cholesterol on whatever treatment you've been prescribed. And that if your cholesterol is tested and found not to be in good control, you'd expect to get a dose increase. But what I would say is that people should just ensure that they're taking their prescribed medication for the time being, persisting with that. And ideally that should be a high intensity statin, because that's what's recommended in the NICE guidance. We have also had some concerns that people may have difficulty in obtaining supplies of their normal statin, but we've been reassured by colleagues in pharmacy departments around the country that there is no supply issue, but there are certain brands of generics that are sourced from Europe and elsewhere in the world to, if you like, give the best price for the pharmacists who are dispensing these, and they may therefore have to switch to different brands of generics that are available within the UK, and that may in some cases have led to a temporary interruption for an individual case. But broadly speaking, there are plenty of supplies of all the medications, and we've no concerns in that way. So those are the main things that we've been hearing as far as I'm aware.
Yeah, I definitely feel like you broke the ice with Donald Trump. So fake news, be on the lookout. Yeah. There's an awful lot of stuff going around in the media that is very misleading, and a lot of patients have got in touch with us and healthcare professionals to kind of say they are very concerned about what they should be telling their patients and what the actual facts are. As Dermot said, there shouldn't be an issue with supply chains for the most part. Some of the earlier issues were, in fact, that people were trying to overorder their medications and get too much supply, more than they would normally need. And this seems to have settled down now in line with people reducing the buying food in bulk as well. So people seem to be calming down a bit, which is definitely good. So when it comes to managing high cholesterol in primary prevention, there were already issues before this pandemic. There were already problems where people weren't either following up with their GP or not going in the first place. So if someone's had a diagnosis of high cholesterol, but they haven't been followed up by their GP, what would they need to do at the moment, Dermot?
Well, if the high cholesterol has been identified as a problem, what the general practice rule at that point is to give the person diet and lifestyle advice, discuss with them treatment options should diet and lifestyle advice not be effective, and then generally do a reassessment with a Q-risk score being performed at that point to see if they would qualify, if you like, as a greater than 10% 10-year risk who would likely benefit from statin treatment. Now, I guess that some people may have been, going through this process, and if they have, I think the best advice for them is to stick with the diet and lifestyle advice for the time being. Remember, this is primary prevention. The intention is to reduce the risk over the next 10 years of a cardiovascular event. So the possibility that they may have a month or two of delay in initiating a statin isn't likely to be a major problem in the longer term, so I wouldn't be concerned about that. I think the one possible exception to that might be people where we believe that going on statin therapy is going to be inevitable, such as people who are identified with familial hypercholesterolemia, and particularly those who are diagnosed with that condition, say in an older age group, say over 50 for male or over 60 for female. You wouldn't, in that case, want any further delay in getting onto statin therapy, and that could be commenced empirically without the need for, if you like, guidance with blood tests in the first place. So I think in the majority of cases for primary prevention, there isn't going to be a major problem with a short delay in starting statin therapy. And often the diet and lifestyle measures may have a very dramatic impact in themselves. And this is a perfect opportunity for people to really sort of practice the diet and lifestyle measures without the sort of burden of having to work normally. In some cases, they've got more time in their hands to sort of eat healthy and exercise regularly. So maybe there's an advantage for some people there.
Absolutely. So the common theme that comes through that we know all along is that obviously diet and lifestyle incredibly important, more challenging during the current pandemic, but there is a huge amount of good information out there about how to exercise, whether that's at home or whether that's in the the once a day that you're able to go out and exercise. People should be taking up that advice. We also have a lot of information on diet online. So for healthcare professionals, on our membership program, which is free to sign up for, we have our Nutrition Academy where we host all of the science behind nutritional guidance. So if you want to access any of that, please do log in, have a look through there. That should help you to speak to your patients if they have questions around nutrition. When it comes to secondary prevention, so we know that people who've already had heart attacks and strokes, they should already be on lipid lowering therapy as a way to reduce their risk of having a further episode. But we also know that they are equally not always optimized. So we've had communication from some patients who have various conditions, including genetic and non-genetic causes of high cholesterol, who've already had a diagnosis of cardiovascular disease. So what would you say to people in those situations whereby their drugs are not optimized and haven't reduced their cholesterol to an acceptable level?
Well, first of all, I agree with you, Chris, that if you have a diagnosis of cardiovascular disease and you will already have been offered statin therapy, and in most cases we hope people will be taking that. We know that even before the COVID-19 pandemic, many people who were sent home with cholesterol-lowering statin therapy, high-intensity statin therapy for secondary prevention purposes, don't necessarily always persist with that. And many of them within the first year will have discontinued treatment, in some cases because they get fed up with so many tablets, in some cases because they believed they were having some adverse effects or whatever. But what I would say to those people is very important that at this moment they need to get themselves into the best possible shape, and they can do that by taking all their prescribed medication, by adhering to healthy diet and lifestyle, by avoiding smoking, if they've got diabetes, by achieving good control, by taking regular exercise, keeping themselves as healthy as possible. If they've been unfortunate enough to experience side effects which they believe are related to statin therapy, I would advise that they should restart the statin therapy. If those same symptoms come back, then there's a possibility that they could restart at a lower dose. We do have some guidance on how to manage lipid therapy in people and for both primary and secondary prevention, but the emphasis is on finding a dose and drug combination of a statin that people find suits them. And it's secondarily important to check that good cholesterol control has been achieved. But I say secondarily important, we know that if you're on a statin at a dose that's within the high intensity range, it's very likely that you'll get the sort of cholesterol reduction that we need to see. If that isn't tolerated, your GP will have the options to offer a different statin at a lower dose, or maybe add ezetimibe. And in most cases, these changes can be made without the recourse to regular blood testing. Certainly, if you've got blood tests available, it's nice to not have to fly on instruments, if you like. But it would be very useful if they could achieve a regular dosage of any statin at any dose, which will keep them that bit healthier. So there is certainly the situation whereby if you're taking a statin and you're able to keep very carefully to the healthy diet and lifestyle intervention, you may actually need less statin to achieve good cholesterol control than before. So you may find that even on the lower dose of a statin, you're now able to achieve better control than you ever believed, because everything else is in better shape. So I just encourage people to continue with that. The same advice largely applies for primary prevention, whether it's low risk, moderate or high risk primary prevention. But as we've discussed before here, we would consider anybody with familial hypercholesterolemia who's a genetic diagnosis. And if that diagnosis has been made, for instance, at a later age, over 50 for a male, over 60 for a female, they should consider themselves, at roughly speaking, the same risk level as somebody who has already had some kind of cardiovascular event, because we know that familial hypercholesterolemia is a very potent cause of furring up of the arteries. And the sooner we get people on good treatment to reverse that, the better.
Absolutely. So statins is ever quite a hot topic. They're in the media all the time, in both positive and negative lights, backwards and forwards. There's very little consistency there. But what we do know is that amongst the medical community and amongst research, there is a consistency in that statins do reduce your cholesterol and also reduce the chance of you having things like a heart attack. So yeah. Nothing new there. The only new thing that's really come about statins recently in regards to the pandemic is about statins and plaque stability and in relation to coronavirus. So most of the evidence comes down on the side of what we already know, which is that statins, amongst many of the properties that they do have, are that they do help to stabilize plaque in the arteries. So one of the reasons why we give statins to people who may have a normal cholesterol, but who have a diagnosis of heart disease, whether they've had a heart attack or not, that's one of the reasons we would give them statins. So in relation to coronavirus, Dermot, do we have a sort of a top tip for our healthcare professionals around plaque stability and statins at this point?
Well, as you mentioned, when statins' ability to lower cholesterol also translates into their ability to encourage the disappearance of cholesterol from lipid-rich plaques, which are the lesions which are most frequently involved in acute coronary syndromes and myocardial infarctions. We know that whenever lipid is deposited in these lipid-rich plaques, there's intense inflammation associated with that lipid deposition. And it's the inflammation associated with this lipid-rich plaque that may result in the instability, plaque rupture, etc. The coronavirus is a situation where in severe coronavirus infection, you do get an intense cytokine storm and an inflammatory reaction superimposed on already inflamed artery with lipid-rich plaques. That could lead then to cardiovascular events, and this is seen during severe coronavirus infection. Cardiac damage, strokes, etc., seem to be happening. So essentially, what we want to have is people who enter hospital, if that's the unfortunate outcome of their coronavirus infection, we want them to be going into hospital in the best possible shape. with their arteries is in as good condition as possible, and if they've been treated consistently with a statin at a dose achieving that greater than 40 or 50% reduction in LDL or non-HDL, they're likely to have most of that lipid material and those lipid-rich plaques will be gone, and their plaques will be much more likely to be stable and less prone to rupture in the context of a severe coronavirus infection. So it's most important that people persist with their medications. If somebody went into hospital and they had to be treated with an antibiotic that might have some interaction with their statin, the intensive care doctors will know what to do and they don't have to worry about it. But what we don't want people to be doing is what Donald Trump would do, is make medical decisions when they don't have a medical degree. And they just stick with the prescribed medication and let the doctors decide when the time comes.
I think for the next webinar, we'll put Trump on the agenda. It seems to be a bit of a theme. So as Dermot said before, just to kind of refocus for a second on FH specifically, so obviously we are the UK's only specialist cholesterol charity covering all lipids and blood fat conditions, and one of the most sort of common of those is FH, familial hypercholesterolemia. We've worked together with Dermot and other professionals who sit on our medical, scientific and research committee to better understand people with lipid conditions, whether they're rare or extremely rare, what situation they're in when it comes to their risk. Dermot mentioned earlier, and just to reiterate, that if you are a man and you were diagnosed and first treated for FH after the age of 50, or if you're a woman and it's after the age of 60, we would class you as high risk, as because you've had high cholesterol for a very, very long time since birth, you've not been treated, and therefore your chance of having heart disease are quite high. This is also the case if you have FH and other risk factors, whether that's high blood pressure, chronic kidney disease, diabetes, and if you have severely increased lipoprotein A levels, 500 milligrams per litre or 100 nanomoles per litre. If you're going above those values and you have FH, you would also be classed as high risk with that risk of heart disease. We have a specific section of our website on coronavirus and FH. We also have a specific section on prescription guidance from Heart UK for people who have high cholesterol, whether that's inherited or not. That's all available on our website. We do also have free professional membership where we have additional documents in there to cover things like suggested ways of dealing with people who may be taking drugs like limiptide, volanesorsen. They may be on lipoprotein apheresis, for example, and those suggested protocols are through professional membership if you sign up for free. Those are available on there too. So Dermot, we've had a question or two come in, so I just wanted to address those as well. So we've had a question about, does being on a PCSK9 inhibitor increase your susceptibility to COVID-19?
There's absolutely no suggestion that would be the case. As I mentioned before, statins appear to be safe in the context of severe infection, pneumonia, etc., with previous viruses that have appeared from previous other community-acquired pneumonia, etc. And remember that PCSK9 inhibitors work in very much the same way that statins do, by upregulating the LDL receptor. There's no suggestion that the LDL receptor is in any way involved in coronavirus infection, and that furthermore, coronavirus doesn't really get into the blood. So it's not a virus that causes a viremia in the same way as, for instance, a blood-borne virus like hepatitis C would. So it actually does not, if you like, interact with lipoproteins in the same way that some other infectious agents would. So we've absolutely no reason to believe that any lipid-acting drug will have any significant interaction, with the coronavirus. So we're not concerned about that, and we would certainly not recommend that anybody would interrupt any lipid-lowering therapy based on, the risk of coronavirus.
you. We've also had some questions about triglyceride management. So obviously an important part of your cholesterol profile is your triglycerides too. Something else that's not particularly well understood across the spectrum. So what would we do about triglyceride management during this time?
Well, I think that the question was raised was, what about somebody who is found to have a triglyceride which is raised above 10 millimole per liter? So, and even worse, above 20 millimole per liter, which is in the range where it would put people at risk of acute pancreatitis. Well, I think the important thing to remember here is that severe hypertriglyceridemia can cause a wide variety of symptoms. Abdominal pain, obviously, is the one that we think of with acute pancreatitis, but you can get respiratory symptoms with severe hypertriglyceridemia. That's not terribly uncommon, and there are a few other symptoms here. If somebody has had a triglyceride measurement and it's above 13 millimole per liter, the guidance that you will see on in the NICE guidelines and so on would emphasize the need to look for secondary causes and address remediable factors that could be contributing to the high triglyceride, and particularly things like excessive alcohol consumption or poorly controlled diabetes. Those would be the first things to look at. And under normal circumstances, those things would be addressed and a repeat test would be done. Ideally then to decide whether the patient's still at risk, in the at-risk range for acute pancreatitis. That may be a bit of an issue at the moment in terms of getting a repeat blood test done, but I think this is a situation where a bad outcome for severe hypertriglyceridemia could be an episode of pancreatitis, which is going to take somebody into hospital with an illness which is at least as severe as the majority of coronavirus infections. So I think this would have to be taken very seriously. But I think in the current climate with people's lifestyles being affected by coronavirus, it's possible that there may be people who are drinking far more alcohol than normal. So that sort of thing should be looked at in the first instance. And if that's clearly involved, it may be that simply telling people to abstain or reduce their alcohol consumption may be enough in the first instance. So those are the sorts of things I think need to be considered. But if a repeat blood test is needed, that's what's needed. It's better than sending them into hospital with acute pancreatitis later on.
Absolutely. We've also had a question about, there's been a few reports of acute rhabdomyolysis associated with COVID-19. This person's had 2 patients who are both diabetic with it in their clinical area. Isn't sure if they were on statins or not, but should that be a risk that we're considering?
I don't think that there is a direct link. We know that rhabdomyolysis does occur in people who are not even on statins at all. It is a complication of severe shock and can happen, in association with dehydration and other, sorts of infections. I think that if somebody's coming into hospital and they're on a statin, as I mentioned before, the doctors who are dealing with those patients in hospital will be aiming to make sure that there is no interaction between the various drugs that could, for instance, increase the risk of muscle toxicity. We know that for the majority of people on statins, with the atorvastatin, the interactions are infrequent, but they're well recognized, and there are tables of interactions that doctors and hospitals can look into. But in somebody, coronavirus is associated with shock, with renal failure, and those sorts of things can also cause the sort of widespread tissue damage, and muscle damage that you can be talking about here. In diabetes, obviously, more severe coronavirus infections may be seen in any case. I'd say that most people with diabetes these days would probably be on a statin, but I don't think that there's any way we would link the statin to the rhabdomyolysis in this situation.
Okay, thank you. We have 1 or 2 more questions which I think we've got time to get to.
Okay.
In the meantime, just a quick plea. We did a poll at the beginning to check people's level of knowledge. I've just launched the next poll. Just want an idea of, after this webinar, after the information you've had so far, how your levels of confidence are doing in regards to coronavirus and lipid management in a healthcare professional setting. So it'd be great to know from you guys if this has been useful or not. While you're casting your votes, I'm going to have a quick look. We've got another question here. So Dermot, not to put you on the spot, you treat acute pancreatitis due to hypertriglyceridemia in an ITU setting. Do you keep them nil by mouth? And when you recommence the feed, is there triglyceride low, NG feed, etc.?
Yeah, well, there's quite a lot of controversy about whether you feed pancreatitis or whether you starve pancreatitis, and I think that the practice is not uniform around the country. But certainly there is monitoring of the triglyceride levels, and you wouldn't be feeding people with anything that's going to contribute to worsening the hypertriglyceridemia. But quite often patients are unable to eat because they just have no appetite and they're not feeling well at all. And intravenous feeding is usually only started after people have been ill for some time. But in the majority of cases, the triglycerides with the starvation that goes with the pancreatitis will come down anyway. There's been some arguments about whether, for instance, treating people with insulin infusions or heparin and such like would improve make the triglycerides improve more rapidly, and some people have advocated plasmapheresis as well. But it would appear that the supportive management that's common for all forms of pancreatitis does seem to be just about as effective as any of these interventions, and they involve less risk to the patient. So I would say that it's generally supportive therapy, and that triglycerides would be monitored to ensure that they are coming down steadily.
Fantastic, thank you. So we've reached the end of the session. Thank you everyone who's voted in our poll. We've actually seen an increase in your confidence as to how to deal with this. That's fantastic. That helps us to understand these webinars are useful. These sessions are recorded, like I said, so sometime early next week we'll get this session uploaded to our professional membership area. So that means that you can re-watch this or watch some bits that you've missed perhaps, and those will start to come through. Any questions that you have that we haven't addressed or we haven't had time for, we have had one about apheresis centres in the UK reopening. If you guys want to email webinars@heartuk.org.uk, we can address your questions through there too. So this is not the end of our support. We are always there equally for patients and healthcare professionals to help them through this time. You'll get a follow-up email just to remind you of the email address you can contact us on within the next 24 hours from Zoom. So thank you very much for joining us. If you found this helpful, please do join some more. We'll advertise through the newsletter, and we can only do these with donations. So if anybody would like to give us a donation towards the work that we're doing to continue to support patients and healthcare professionals, it would be much appreciated. Thank you from myself at Heart UK and Dermot.
Thank you, Chris.
Thank you very much, guys. Take care and stay safe.
Okay.
Thank you.
Bye.